Welcome, everyone. We are so excited to welcome Bradley Buchheit here from OHSU, who is going to be focusing on medications for OUD and the foundations for prescribing. So folks can please welcome Bradley.
Hey, everyone. Excited to be here. So this morning, we are going to talk about foundations for prescribing medications for opioid use disorder. Later on today, we're going to go into details on how to initiate medications for opioid use disorder. So this is sort of like the pre-version of that talk. And so we won't go into a ton of detail specifically to around initiating the medications, more just sort of why we think it's a good idea to use medications for opioid use disorder. So I have nothing to disclose, and we won't be talking about any unapproved uses of pharmaceuticals or devices. So at the end of this activity, hopefully you will all be able to describe the physiology of addiction, identify diagnostic criteria for opioid use disorder, list the FDA-approved medications that we use for opioid use disorder, talk about harm reduction and apply its principles in day-to-day interactions with patients, and then recognize how stigma can impact how individuals either seek treatment for substance use disorder and can improve engagement, if we limit stigma, can improve engagement with people who use drugs in a healthcare setting. So I'm sure all of you are aware that we're in the midst of an overdose crisis in the US. Most recent data from 2021 is reporting 80,411 opioid-related overdose deaths in the US over the age of 12. Oregon specifically has seen a 6-fold increase in deaths due to fentanyl between 2019 and 2021. So this really isn't just the United States, it's happening here in Oregon as well. Specifically looking at adolescents, so 12 to 17-year-olds, we're also seeing record overdose deaths. This dashed line here sort of was when the pandemic happened, so it's pre and post-pandemic, but between 2019 and 2020, we saw a 4-fold increase in fentanyl overdose deaths in this age group. So it's really, historically impacting adults. Now we're seeing it impact our 12 to 17-year-olds in a really dramatic and terrible fashion. So let's talk a little bit about addiction. You probably all know this, so it'll be a review, but if you're like me, I sort of glazed over when we did neuroanatomy, and so I will try my best to describe how addiction works. So thinking about opioid receptors, right? We know that there are 3 types of opioid receptors in the brain: mu, kappa, and delta receptors. When we talk about overdose, when we talk about pain management, when we talk about respiratory depression, the mu receptor really is the key receptor that we're talking about. And that's the one that initiates all of those sort of euphoria, pain relief, those types of things. And we don't know a ton about the kappa and delta receptors. And so when people say, oh, it's an opioid agonist or it's an opioid antagonist, they're really talking about mu agonist, mu antagonist. The kappa and delta receptors can play a role in pain, but for our purposes, speaking about addiction, we're really talking about those mu receptors. And so where are those mu receptors? So they're in the prefrontal cortex, they're in the thalamus, the nucleus accumbens, the ventral tegmental area. So I just need to adjust my notes here so I can actually see them because they are super tiny. So when opioids bind in the thalamus, you get analgesic properties. When opioids bind in the prefrontal cortex, it contributes to impaired thinking and an individual's decision about how important that substance use is to them. So when it activates those receptors in the prefrontal cortex, that's sort of what it's doing. And then when it activates those receptors in the nucleus accumbens or the ventral tegmental area, the VTA, it's associated with that euphoria. So when people say, oh, I felt high when I took that substance, that's really where they're sort of seeing those activations. And so thinking about, positive and negative reinforcement about motivation and how that plays into addiction. And so when opioids act on our basic motivational systems in the brain, in the brainstem area, it really is activating our reward pathways. And so they involve really the nucleus accumbens. And so opioids stimulate release of dopamine in much greater activity than we would normally experience, right? So you have a hamburger for lunch, you love hamburgers, your dopamine release is a little bit, right? So you're gonna eat a hamburger again. When you take an opioid or smoke some methamphetamines or smoke a cigarette, right, like that dopamine release is magnitudes greater than that. And so thinking about how that can sort of take over your normal physiology is important. Oh, dang, well, I can't go back. But anyways, the other thing to think about is negative reinforcement. So the nucleus accumbens, when it's activated by opioids, it reduces stress. And so not only are you having euphoria, but you're also having reduction in stress. And so that sort of re-triggers you to think like, oh, I took this pill or I smoked this and it made me feel this way, and it reinforces continued use. Looking at how addiction actually changes the brain. So historically, right, addiction was not really thought of as a chronic medical disease. Now we can actually show with PET imaging that there are actual changes related to dopamine receptors in the brain of people who use opioids chronically, whether that's heroin, oxycodone, fentanyl. So we know that there are changes, and so that can sometimes help individuals when you're talking to them about substance use who may be resistant to this idea that it's a chronic disease and that's actually changing some of the way that your neurons are working in the brain, and you can show it via imaging. This is from an article in the New England Journal of Medicine by Nora Volkow. It's pretty much similar, sort of discussing similarly these sort of like cycles and stages of addiction. And so if you think of someone who's using a substance for the first time, right? So whether that's binging on a substance or being intoxicated on a substance, it activates your reward regions here, which are blue. And then that activation is enhanced by the conditioned cues of whatever you're using, right? So if it's a pill, popping a pill could theoretically activate those same cues. If it's smoking and you're using aluminum foil, seeing aluminum foil could activate that same cue. And so it's conditioning yourself to say, hey, when I see this, I want to feel that thing that I felt before, right? And so then if you think of those cue areas and how they get sensitized, those are really the green areas. And then after your intoxication episode, often people will feel withdrawal, right? And so how does that work in this pathway? And so during withdrawal, it activates regions of emotions. So that's like the pink area here. And it results in negative mood, enhanced sensitivity to stress. If anyone's ever seen someone who's in acute opioid withdrawal, how chatty and friendly are they? Right? Not very chatty and friendly, because they're feeling terrible, and they're feeling a lot of stress, and they're feeling anxious. And so this is all sort of described here by the changes in the brain. And then you get to the sort of preoccupation and anticipation stage. So maybe they're no longer in withdrawal, but they remember being in withdrawal, or they remember that euphoria that they felt when they were intoxicated. And so this decreases, so the prefrontal cortex is really how we sort of manage making decisions, right? If we didn't have a prefrontal cortex, we would just do and say anything that comes into our mind. And as our prefrontal cortex develops, it says, this is socially acceptable to do or to say. And so when people continuously use substances, their ability to stop themselves and say, maybe this isn't a great idea, or I don't really want to use opioids today, sort of decreases with time. And so they sort of get into this vicious cycle where they can't stop themselves. And that's when individuals end up with developing a substance use disorder. Now, specifically for adolescents, right, if you think of their brain development, by the time they're in their sort of mid to late teens, their reward system is completely developed, right? Their planning centers, their prefrontal cortex is still developing. So they may not have those cues that are telling them, oh, this is probably not a good idea. So I think of the prefrontal cortex as maybe the brakes of the brain and the reward system of the gas of the brain. And anyone who drives a car knows that if you don't have brakes, it usually doesn't end well, right? And so if your gas pedal's fully developed and you're zipping down the highway, but your planning center or the brakes isn't very developed, then bad things can happen. And so it really sets up adolescents and young adults to be more susceptible to some of these risks associated with substance use. And so use of substances during this critical time can also change sort of long-term outcomes related to their development. Questions about physiology of addiction?
This is making me think of PTSD, right? Where we avoid cues or we engage in things that are going to make us not feel those cues. Does that resonate?
Definitely, yeah. So often I hear my patients tell me it's the people's, places, and things that they need to get away from. And this, when I was a fellow, I remember someone telling me a story that I would have never really even thought of. It was someone who was using stimulants, and they usually smoked them on aluminum foil. And they told me that when they're at the grocery store, they had 5 years of recovery. When they're at the grocery store, they wouldn't go down the aisle where they had Ziplocs, aluminum foil, saran wrap, because it was super triggering for them. And when they saw the box of Reynolds aluminum foil, they thought of methamphetamine, and that was just like too much for them. So like, I think that those cues are really, really big. Other questions? Okay, so now that we know how addiction works and how it impacts the brain, let's talk about how we diagnose opioid use disorder. So you probably are aware of DSM-5. It sort of outlines how we diagnose substance use disorders. Looking at substance use disorder diagnostic criteria, there are 11 criteria. There are 5 main categories. So I don't know if you're anything like me. I have a hard time remembering anything, let alone 11 criteria. So if you can remember 4 C's, craving, control, consequences, and compulsion, then you're probably going to be able to at least diagnose a mild substance use disorder, right? If someone has 2 of these things, then they're probably going to have 2 of the DSM-5 criteria. If they have 4 of these things, they're probably going to have at least 4 of the DSM-5 criteria, and 4 is a little bit easier to remember than 11. And then there's also pharmacologic, so withdrawal and tolerance, and then the DSM-5, really, you can only utilize it per DSM manual on 9 different substances: alcohol, cannabis, hallucinogens, inhalants, opioids, stimulants, nicotine, sedatives, hypnotics, and anxiolytics are all one. And then caffeine. Although they say that you can use it on caffeine, no one really recognizes caffeine use disorder as a true diagnosis. So it's an interesting caveat for DSM-5 and caffeine. But we're here to talk about opioids. So here are the actual 11 criteria. I think the important thing to note is check your EMR. There's probably a list somewhere. And so if you can't remember the 4 C's and you can't remember all 11 criteria, you can at least remember where in Epic or PowerChart or whatever you use that there's a list of these 11 things. One thing to note is you have to have 2 of these to meet criteria for a substance use disorder, unless it's just the 2 pharmacologic criteria, right? So imagine you're prescribing someone an opioid for chronic pain. They've been on it for years. They probably have tolerance to opioids. They probably will also have withdrawal from opioids if they've been taking it daily for 2 years and they abruptly stop it. Does that mean that they have an opioid use disorder? Well, technically they have 2 of these criteria, but since it's only the 2 pharmacologic criteria and they're not having the other 4 C's, then they don't meet the criteria. If it were tolerance and they got pulled over for driving intoxicated, or that they overdosed after using benzos with their opioids, or that they got hepatitis C from injection drug use, then at that point, those 2 criteria would count for a substance use disorder. But if it's just tolerance and just withdrawal symptoms, then it wouldn't. And so how do we define severity? So if they have 2 to 3 of these, it's a mild disorder, 4 to 5, a moderate disorder, and anything 6 or greater is considered a severe disorder. I think it's important to know severity specifically for opioid use disorder because a lot of FDA-approved medications are based on whether they have one of these severities. When it comes to nicotine use disorder, right, like I don't really care if it's mild, moderate, or severe because all of the meds are FDA approved for nicotine use disorder. They don't say, well, you can only use Chantix for moderate opioid use disorder. But for opioid use disorder, like if you're going to a methadone clinic, you have to have a severe opioid use disorder to initiate methadone at an OTP. If you are starting bup, technically you're supposed to have a moderate or severe opioid use disorder in order to initiate buprenorphine. So I think it is a little bit more important to be as specific as possible with severity. So an example, you have a 17-year-old who's coming into your clinic looking for an oxycodone refill, recently had an ACL repair after a tib-fib fracture 4 weeks ago while skiing. They're going to PT, they're taking Tylenol, they're taking ibuprofen, been on opioids for the past 4 weeks, and they ran out of meds 3 days ago. And when you see them, they're experiencing myalgias, sweats, chills, nausea, and you're giving, the prescription is 5 to 10 milligrams Q4 hours as needed, and they're taking it every 4 hours, every day. Thoughts on whether this individual might have a use disorder?
It seems like they were definitely physically dependent for sure.
Definitely.
Definitely physical dependency.
Yeah.
Whether or not it's a use disorder, don't know.
Probably need some more information. Exactly. I think I completely agree with you, right? So it could just be, right, they've been on these opioids for 4 weeks and they're feeling some mild opioid withdrawal symptoms because they're used to having that in their system. But that doesn't necessarily mean that they have a use disorder. However, you dig a little bit, right, I would say that this is probably the only criteria, at least based on the information that we have, that this individual is meeting. So one criteria, not meeting that criteria for substance use disorder because you need at least 2. But then you dig a little bit deeper, you check the PDMP, and since they last saw you, they went to the ED twice and got 2 prescriptions for additional oxycodone, and you would have expected that to last them, 10 to 14 additional days, but they're coming to you now saying that they're out. They report that they are taking more than you prescribed them because they like the feeling when they take the substance. They tried to stop or cut back, and it was really challenging for them. Their friends at school are worried about them because of their use, and they feel like they've not been studying as much because all they're thinking about is opioids. So now, right, we probably could say that based on the fact that taking more than prescribed, based on the fact that he's tried to cut back and been unsuccessful, based on the fact that that friends are worried about them, that he's not doing as well in school. I would suspect now that he is probably having some tolerance because he's using more to get the same euphoric effect, right? And that he's having withdrawal because he presented with those symptoms. And so 6 criteria, I would say, a severe substance opioid use disorder for him or that person. Questions about diagnosing?
Does time matter? So that was only on it for a month as opposed to a year?
Yeah, so time doesn't technically matter. However, when you're assessing DSM-5 criteria, it's in the last 12 months. So if someone is coming to you and 16 years before that, they were overusing their opioids, then you wouldn't technically utilize that in determining if they had a new opioid use disorder. Although if you had that diagnosis, you could say that they had opioid use disorder in sustained remission, which is if you've not had any of those 12 criterias for greater than 12 months is sustained remission. Early remission is if you've sort of been in recovery from that substance for 3 months or greater. Yeah. Other questions? Okay. Let's jump into medications. So there are 3 FDA-approved medications to treat opioid use disorder: methadone, buprenorphine, and naltrexone. Methadone is the only full agonist opioid that is FDA-approved to treat opioid use disorder. It is limited access if you're under the age of 18. Most opioid treatment programs, or OTPs, require you to be 18 or older to initiate methadone. There is one caveat to that. If you are under 18 and you have tried treatment on 2 separate occasions and it has failed and you have parental or guardian consent, then you may initiate methadone per federal regulations. But it is hard. And to be honest, I don't know if methadone clinics are great places for 12 to 17-year-olds to be. But that's sort of what the environment that we're working in as far as systems. You do have to dose daily when you're on methadone because you can't prescribe methadone. It can only be dispensed at a methadone clinic. And you can get take-homes where sort of you'll go and present, dose once, and then they'll give you a dose for the next day, and so you would come every other day. But that takes a while to get those take-homes, usually about 90 days to get the first take-home. Although that is hopefully changing with some of the methadone regulations that are being pushed through Congress. Buprenorphine is a partial opioid agonist. So what does that mean? When it hits that mu opioid receptor, it activates it 30 to 50%. So unlike methadone, where it's activated 100% of activation, buprenorphine only activates at 30 to 50%. It is FDA approved for anyone over the age of 16. It helps with withdrawals and cravings. It's usually daily dose. Sometimes people take it once a day. Sometimes people take it twice a day. I even have some patients who take it 3 times a day, especially if they have co-occurring chronic pain. But in general, it's also a very long-acting partial opioid agonist, and so really once or twice daily dosing is acceptable. It comes in a tablet form that is dissolved under the tongue. It comes in a long-acting injectable formulation, and it used to come in an implant, but I don't think that that actually exists anymore. So I have to update my slides. And you used to have a DEA waiver to prescribe buprenorphine, and now you don't. So anyone who has a DEA number can utilize and prescribe buprenorphine. Naltrexone is an opioid antagonist. So when it binds to that mu opioid receptor, it blocks any other substance from binding there, and it activates it 0%. So naltrexone is approved for anyone over the age of 18. It reduces cravings, but because it's not activating those receptors, it's not really helping with any withdrawal. It comes in a daily dose tablet. However, the oral formulation has not been shown to be more effective than placebo. And so if we're utilizing naltrexone for opioid use disorder, we tend to use the long-acting injectable formulation. The one scenario where the oral formulation has been shown to be somewhat effective is if someone is watching an individual take the dose daily. So like they're in a controlled environment, which is often challenging. Again, you don't need any special license to prescribe naltrexone. So how efficacious are medications for opioid use disorder? So this is all data in adults, which I apologize. A lot of the stuff that I'm presenting is data in adults because we don't have a ton of data in young adults or adolescents. But we know that buprenorphine and methadone reduce overdose risk by 60 to 80%. 60 to 80%, right? Number needed to treat for buprenorphine, for engagement of someone to come back for that second buprenorphine script. Any guesses? Number needed to treat? 2. If you give 2 prescriptions, one of those people will come back for the next prescription, right? There are very few things in medicine where a number needed to treat is 2. So prescribe buprenorphine for people who have opioid use disorder. It's been shown to reduce non-prescribed opioid use. It's been shown to improve retention and treatment, which we know usually is equivalent to not using substances. And it reduces risk of Hep C and HIV because they're not injecting substances anymore, right? Naltrexone, once people are on it, it is almost as effective as buprenorphine and or methadone. The challenge with naltrexone is people have to be opioid-free for 7 to 10 days before you can initiate it. which can be hard, right? Opioid withdrawal is not easy to get through, especially if you have to get through 7 to 10 days without an opioid. Times where naltrexone is really great is coming out of incarceration, coming out of detox or residential treatment. And so those are times where naltrexone would be ideal. There's also some data that's coming out that's showing that overdose risk after naltrexone is actually higher than it would have been if they never started naltrexone. And think about that a little bit, right? If you have someone who's on naltrexone for a month, they've not been using opioids for a month, that means all their opioid receptors have been blocked by something that won't allow anything else to activate those receptors for a month. And then they don't show up for their next injection, and they use the same amount of opioids that they were using before they got the injection. Usually doesn't end well. So I think retention is challenging in naltrexone, but like I said, it works well for people who it works well for, and it is FDA approved. Questions about meds? Yeah.
For all the treatments. Thank you. No, so all these different treatments, are there any baseline labs that need to be done or follow-up labs before?
Yeah, so we'll talk about that a little bit more when we do the initiation of MOUD later, but there are some general labs, usually urine toxicology and pregnancy test. Some people prefer to get liver function tests for initiating buprenorphine, but in the fentanyl era, waiting to get a test to ensure that someone doesn't have liver failure when you can probably do a physical exam and determine that they don't have uncontrolled or cirrhosis, right, or decompensated cirrhosis is probably not necessary in otherwise young and healthy individuals. So I think pregnancy test is probably the only thing that you would really need, and even that, like, you can just counsel people, like, if you get pregnant on these substances, your child may have a risk of neonatal opioid withdrawal syndrome, and initiating it quickly and like there on the spot, I think, is key.
Do you have a question? I do.
Oh, yeah. So I think some of the challenges in prescribing bup to youth are them having access to it and their parents needing to lock it up and give them the medication every day. So I think Sublocade could be really useful, and also with adherence. But my question is, that's only FDA approved for 17 and above. Are you using that, or do you know anybody who's using that in under 17?
So there have been some case studies. I don't know of any places in Oregon that are using Sublocade under the age of 18. But great question. This really highlights the dearth of evidence that we have in adolescents and young adults when it comes to substance use treatment. So there is a little bit, oh yeah.
So I guess my question or comment is sort of a follow-up to that. So I did like 20 seconds Google Scholar research, where the NIMH stuff said, the evidence isn't there, but people are dying, so you just have to go do this. And, I guess that's what I'm trying to convince our team, because we lost 4 youth. I don't know what happens if prescribers start saying we've got to do the thing that's actually going to work for the youth right now.
Yeah, I think so. I think, like with anything in medicine, it's a risk-benefit discussion with the patient and the parents or guardians. And so, sublingual buprenorphine is also only FDA approved for 16 and older. I've definitely seen it used in people younger than 16 who are at super high risk. And so, we know that there are risks associated with fentanyl use. We know there are risks associated with any medication that we prescribe someone, but talking about sort of long-term goals and what patients want, I think, is key. So as far as there is some evidence in adolescents and young adults for the efficacy of these medications. So we know that if you use buprenorphine in this age group, so the 12 to 24-year-olds, they in general tend to have less opioid-positive urines. And when I say opioid, that does not include buprenorphine. We would hope that they would have buprenorphine in their urine if we're prescribing it. They also have longer treatment retention, which I think is key. There was one case series looking at extended release naltrexone in this age group, and they had 63% retention and 56% good outcome. So how do they define a good outcome? It was if they didn't have any new consequences of substance use, if they had an improvement in one of their sort of day-to-day functioning domains, and that they had negative urines for opioids is how they defined a good outcome. And then we also know from evidence on claims data is that access to medications for opioid use disorder in this age group is abysmal, even after an overdose. So they did a study looking at 13 to 22-year-olds who came in with a non-fatal overdose, and only 2% of them left with an medication for opioid use disorder. 2%, 2 out of 100. So I think one of the things that we can do is just start prescribing, and it's going to be helpful. And then this was looking at individuals in the 12 to 17 age group versus the 18-25 age group, and that they were less likely to receive MOUD in both Medicaid and commercial populations. What do our national leaders have to say about recommendations or guidelines? Well, both the American Academy of Pediatrics and the American Society of Addiction Medicine think that offering medications for opioid use disorder is reasonable and part of standard of care, especially if they have a severe opioid use disorder. So, before we jump into harm reduction and how do we apply it to our day-to-day encounters, questions? Knowing that we're going to be going into a ton more detail about initiating these meds this afternoon.
So what would you attribute the fact that only 2% of youth are, after having an overdose or walking out, having a prescription?
Yeah, I think there's a number of things that are attributing to that. One is that we used to have an X waiver, and if you looked at the data for pediatricians who were X waivered, not a ton, right? The other issue, I think, is that in general, there's a lot of stigma around using medications in this age group, whether it's stigma from the patient themselves, stigma from the family, stigma from the state, stigma from the federal government, right? And so I think that plays into it, and sometimes stigma from the recovery community itself. Oh, yeah. So I think that those are probably the main things. And then, where do people follow up after you initiate, right? They're coming to the emergency room, and you start a medicine, and then no one's willing to continue it. Then what happens then? So I think that there are a number of issues. Yeah.
And I would just say also, FDA constraints. I mean, we want to be able to prescribe, but we just don't have, the FDA hasn't approved a lot of these medications in children younger, and we know that kids are using younger and younger, and so we have really risk-averse providers a lot of times who are putting their licenses out there to prescribe things that are not necessarily FDA approved, and those are conversations you have to have risk-benefit conversations with the parents and with the clients, but the data just isn't out there to support the practice yet.
Don't people prescribe off panel?
Yeah.
I know.
Yeah.
But this seems to be a more risk-averse, people, I think it's the stigma.
Well, I think some of it, right, is why was it set up for us as prescribers to be able to give anyone an oxycodone script, but you needed 8 hours of additional training to give a medication that safety profile is substantially superior? And so I think that it sets people up to be it must be hard if I need 8 hours of additional training. And so maybe, I don't really want to do this because it's hard or it puts me at risk. When in reality, it's just as easy as maybe not quite just as easy as prescribing antibiotics, but if you do it enough, then you can learn how to do it successfully and effectively. But that's gone now. So. Okay, let's talk about harm reduction or harm minimization. So what is harm minimization? It's a range of public health policies designed to lessen the negative social and or physical consequences associated with a human behavior. So examples of harm minimization. Who drove here today? Who used a seatbelt? Hooray! We all did harm reduction this morning. right? So we know that there's inherent risk in driving. But to reduce our risks, we put a seatbelt on when we get in the car. And so it's the same idea, right? Like we know inherently some people are going to decide to use substances. And so if we can talk to them while they're using substances and teach them or give them information about ways that they can use substances more safely, while recognizing that any substance use is dangerous, right? No one's saying that we're approving all youth to use drugs. What we're saying is if a youth decides to use drugs, we need to make sure that they have information to make the best decisions that they can, right? So maybe letting them know that that pill that looks like an oxycodone tablet is probably fentanyl. Do you know what fentanyl is? Do you know how potent fentanyl is? Have you ever heard of naloxone, right? So those types of conversations, again, have not been shown to increase substance use, but they have definitely been shown to improve outcomes and dangers associated with substance use. Naloxone. So naloxone is super important. For those of you who don't know, naloxone is an opioid overdose agent. It comes in these amazing little spray intranasal kits, super easy to use. This is sort of just a study looking at how prescribers counsel people around naloxone. And after this health center started initiating counseling and had a team member that helped with it, most providers at the practice felt more comfortable talking to patients about naloxone and discussing opioid use and or addiction with providers. Most patients reported after having this conversation about naloxone, people felt more comfortable opening up and saying oh, this person really cares enough about me to give me this antidote to reverse overdose. Maybe they would care enough about me to talk about treatment options for my opioid use, right? So I think that it's a nice way to break down some of those barriers that are often associated with feeling like patients don't want to give providers information about this because they're going to be judged. So who should carry Narcan? Everyone. And that's just not my opinion. The Surgeon General from 2018 also agrees with me. So I carry Narcan. I have some in my bag right now because you never know when you're walking down the street or taking the bus to work or on the Max who might need it. And so I would encourage everyone, if you don't carry Narcan, to carry it. And then more other forms of harm minimization is talking to people about overdose prevention and safer injection practices. Again, often when adolescents are using substances, they don't initiate their substances via injection. However, there are some cases where people do. And so in those scenarios, or you're sort of 18 to 22-year-olds who maybe started using substances when they're 12 and they sort of progressed to injection drug use, I think it's really important to talk to them about how they can be safer when it comes to injecting. So making sure that they're not reusing needles, making sure that they're not sharing needles, making sure that they're not reusing or sharing their cooking supplies, making sure that they know how to use an alcohol prep pad before injecting. So I had a patient one time, I was like, walk me through how you prepare your drugs for injection and you actually give yourself the injection. They went through all of it. I was like, oh, this is going great. I don't need to counsel you on any of these things. And then she got to the point where she's like, and then I find the vein and I stick in the needle until I get a flash, and then I inject, and I use my alcohol prep pad to clean the blood away at the end. And I'm like, oh, right? We use the alcohol prep pad to prepare the skin before you do the injection. She's like, well, I had just showered, and so I didn't feel like I need to. And so we had a nice conversation about microorganisms that live on the skin naturally and how we use the alcohol prep pad to reduce the risk of introducing those into the bloodstream. So the other thing that we tell people, if they're rolling cottons, not to use their fingers because fingers are dirty. So usually if you go to a syringe service program, they'll give you these little dental cottons that you can shake out of a bag so you don't even need to touch them. Because for those of you who don't know why you use cottons, you usually stab the cotton with the needle and then draw up whatever you're injecting through that so that there's not big chunks of it in the syringe. So not reusing those or rolling them with your fingers, using sterile water if at all possible, and then talking to patients about PrEP, PEP, and safer sex, especially if they're using stimulants, is key. And then as far as overdose prevention, making sure that they're using under direct observation. So what I usually tell people is not in the bathroom, not in the kitchen with like mom in the other room. It really needs to be someone there who's visually watching you, because when you use fentanyl, you can overdose very quickly. And so someone needs to be available to utilize naloxone if needed. Tester shots, does anyone know what a tester shot is? So if you hit a vein, you give yourself a little bit and see if that batch is as potent as what it was, and then you can always give yourself more if need be. Often people who are injecting and have been injecting for long periods of time don't have great venous access, and so if they hit a vein, they're not gonna do a tester shot, but something just to like know what it is, because patients may talk to you about it. And then making sure they know what to do in the setting of an overdose. Do they have naloxone? Do they know how to administer it? Do they know how to do rescue breathing? Should they call 911? Yes, right? They should call 911, start rescue breathing. And then recognizing that if someone's coming out of detox, or if someone's coming out of residential treatment, or if someone's coming out of incarceration, their risk of overdose is substantially higher than if they would have not been coming out of those facilities, and making sure that you talk to people about that. So questions about harm minimization. Yeah, post-exposure prophylaxis. So the question was, what is PEP? So it's evidence-based harm reduction. Can reduce transmission of HIV, Hep C, reduce overdose deaths, increase engagement in formal treatment programs, and it's cost-effective. And I just want to highlight that it does not encourage drug use. And does not result in non-drug users to initiate drug use. I also, oh yeah.
Sure. Do you know what the incidence of transmitting HIV, Hep C from sharing straws and snorting?
I don't know the answer to that. But that's a great question. I also tell people the same, like not to share smoking devices, and if you do, you can. Often syringe service programs will have like little like caps on the pipes, so you can sort of take that like plastic piece off, and sort of, so you're not putting your lips on the same piece as everyone else. But ideally, you wouldn't be sharing any of those things. Yeah. I would also argue that telemedicine is a form of harm reduction, right? So especially in young adults, like the last thing they want to do is come into the clinic and talk to me. But if they are in their bedroom on their phone, it might be more reasonable for us to have a conversation. And so some of the preliminary data about telemedicine shows that it increases access, it improves convenience for patients, and can increase initiation and engagement in treatment. There are some potential drawbacks, right? Some people aren't technologically savvy. And so that can be problematic. Some people don't have access to high-speed internet. That can also be problematic. Some people don't do as well when there's less structure in their treatment program. So that can potentially be a problem. And then it may impact the patient-provider relationship. Although I've done a lot of addiction telemedicine, and I think that you can have just as great of a patient-provider relationship. It's just a little bit different. So, has anyone counseled people on harm reduction in the clinical setting? Great. How do you usually start those conversations?
I try to make it really relatable, like, hey, like, my like biggest concern is always your safety. I really would prefer you not get harmed or die. So here are some things that we can do. I don't know that I would do that as bluntly as with kids, although maybe. But I usually just start really like my biggest concern is always your safety, and like not just making the assumption that things are going to happen, right? So it's just like, oh, no, I'm going to be sober. Great, but you know, maybe your friend or maybe this. And so just kind of being really frank and just straightforward.
I'll just say your
I guess just the adolescent development piece of that. I was reading the other day something that, like, it's one of those you've always known and it blows your mind. This was some research about talking to first diagnosis of schizophrenia, that there's a lot of research that says that when a young person is diagnosed with a serious and chronic condition, their risk behaviors escalate. When a person of our age is diagnosed with a serious and chronic condition, we get really cautious. So just reiterating what the woman who was a mom and a provider said, is like this is, I'm scared conversation, or this can be really bad for you, is less useful than, hey, when you're out there, here's some things to know.
Yeah, I think that's really important.
So I do work with adolescents, and I am very straightforward, just like Kat said. And I find that when I am straightforward like that, they're often really taken aback and surprised because they're not used to being treated that way. And then I have a lot better luck continuing the conversation. And
Yeah. I think being as direct as possible, and motivational interviewing is key, right? So tips and tricks that I found is like asking, hey, is it okay if I just give you some information? Sometimes I'll be like, oh, well, why is this doctor asking me if it's okay that I get information? So you sort of give them some autonomy to say yes or no. I mean, if they say no, then it's like not ideal. But you can be like, okay, well, maybe we don't want to talk today, but let's like talk later. But I am going to tell you about this naloxone that I'm going to prescribe to you because I want to make sure that you know that you can be that you stay as safe as possible. And then next time, maybe we can chat more, right? But if they say yes, then I usually will dive into sort of like maybe like what substances they're using and how they use it, and sort of ask them if it's okay that I ask them a few questions about all of that. I also think that if you learn some of the lingo, so if one of your patients says something, ask them what they mean. So I had someone the other day be like, oh, I've been using Fetty on the street. And I'm like, can I ask you a question? She was like, yeah, you've been asking me a ton of questions. I was like, what's Fetty? And he's like, fentanyl. I was like, oh, okay. I was like, okay, right? So, and like, these are things that I don't really know, but when you are talking to someone and they're using some slang or like lingo that you don't know, asking about it, and then potentially using it later on can give you a lot of street cred with your patients, which I think is important when you're trying to connect with them about like how to keep them safe. Right? So I think those are some things that can be helpful. And then recognizing that they have the autonomy to make decisions, right? Like, I'm telling you that all substance use is dangerous, but I'm also recognizing that you're almost an adult and you're making your own decisions, and some of those decisions may put you in a really dangerous place. Can we talk about making them less dangerous?
I just wanted to say that kind of ties into something I wrote down from Tony this morning. Like, it was, I don't think he used these words, but it's like explain, engage, like empower. And so explaining, asking first, like really giving them, I think that's awesome.
Yeah. And usually, I mean, these conversations, honestly, surprisingly, in my experience, go really well. Because people recognize when you're trying to help them stay alive, usually. And you're approaching it in like a non-judgmental way.
I found that particularly with Narcan conversations, coming at it not only from like something that can help you and help save your life, it's also your friends. And this is something that you can do for your friends, that you can help keep your friends safe too. And whether they admit that they're using or not, sometimes they're a little bit more apt to say, yeah, well, I do have friends that do this, et cetera. And here's how you can keep your friends safe. So we come at it from that perspective a lot of times, and we've had a lot of success with that.
Yeah, and I think that's a good point, right? Like when we prescribe naloxone, it's not really for that person. If you can give yourself naloxone, you're probably not overdosing. Although there have been some case reports where people have thought that they have been nodding out, right, or overdosing, and so they quickly Narcan themselves. But in general, the Narcan that I'm prescribing for that person is not usually for them. Occasionally, if it's in their pocket and their friend knows it's there and they grab it out and they give it, then yes. But I do the same thing. I sometimes will have adults that be like, no, I don't need naloxone. Like, well, do you take the city bus or do you ever walk down the street? Yeah. Okay, well, you may encounter someone who would be like having difficulty breathing. You should carry naloxone, because like what would happen if you didn't have it and you wish you did versus having it and never need to use it? And usually people are like, oh, okay, yeah, that sounds reasonable. You can send it to the pharmacy. So those I think are all really great points. Okay, this is also a fantastic article specifically about adolescence and harm reduction, written by one of my amazing colleagues, Dr. Mike Weiner, who's at Hooper and OHSU, as well as Scott Hadlin and Sarah Bagley at MGH and Boston Medical Center, respectively. And it will go through, we're not going to go through all of this, but it goes through general approaches, specific substances, infectious disease transmission, all of this stuff, and ways that you can tailor that specifically to adolescents. Okay. So let's jump into stigma and how it can impact how we treat opioid use disorders, and then also try to develop ways that will improve how we engage people who use drugs in a healthcare setting. So stigma is real when it comes to substance use and substance use disorder treatment. This was a systematic review of 28 studies, and that it pretty much showed that there are negative attitudes of health professionals towards patients who use substances or have substance use disorder, and that really impacts healthcare delivery and outcomes. And so I think it highlights that there are consequences for stigma in healthcare for this particular group of individuals. And so I think one thing that we can do that's pretty easy to change is making sure that we're describing substance use disorder and addiction in ways that are appropriate. So using person-first language, so it's not an addict or a junkie or a druggie, it's a person with a substance use disorder, right? Making sure that we're using accurate terminology. So it's not really opioid abuse, that's not a diagnosis anymore. That was a diagnosis in DSM-4, but we've moved to DSM-5, and so it's no longer listed in there as a diagnosis. And so making sure that we're saying substance use disorder or opioid use disorder mild, opioid use disorder moderate, opioid use disorder severe, so that other people in your practice or who are seeing the patient outside of your practice know that you actually went through the time to determine that this person has a moderate opioid use disorder, which means, right, that they met 4 to 5 of those criteria. And so you can be as specific as possible, and having like good diagnostic clarity that sort of is objective. And then also making sure that we, avoid terms like addicted babies, like babies don't come out of the womb clawing for their next fix of fentanyl, right? And so they come out of the womb usually dependent on opioids and may have withdrawal syndromes, but they're not addicted. And then really trying to avoid using the words clean and dirty when you're talking about urine toxicology, right? If someone has a positive A1C in your clinic, you don't go into the room and say, well, ma'am, you have a dirty A1C today, right? So why do we say you have a dirty urine? I mean, to me, all urine is kind of dirty, but, saying that someone has a dirty urine just feels bad. And so we should say, hey, your urine was positive for cocaine, or your urine was positive for opioids. Can we talk about that? Very different phrasing, but it just like changes the outlook of the conversation. So these are all small things. And then talking about like sobriety and recovery instead of being clean. Again, these are for healthcare providers. Anyone can use, for individuals who are in recovery, they can define their terminology the way that they want to define it. But I think when we are in a healthcare setting and we're utilizing healthcare diagnoses, we really need to make sure that we're using accurate terms and patient-first terms. Okay. So specifically addressing stigma in medications for opioid use disorder in adolescents and young adults. So this was a great paper by, one of the papers was by Dr. Bagley at Boston Medical Center. And so really this sort of outlines some of the things that we can do to improve uptake. So back to the question that was over here, like how can we improve uptake of medications for opioid use disorder? So one of the things is we can destigmatize treatment, not just like patient destigmatization, but parent destigmatization, right? Making sure that behavioral health providers are also not being stigmatizing towards MOUD, state agencies, federal agencies, people in recovery, right? So we need to destigmatize the use of opioid medications for opioid use disorder. I think this is also unique, right? So, and you sort of got to this a little bit too. When we tell an adult that they have a chronic medical condition, sometimes it's helpful for them sort of comprehend that if we say, like, we're going to be treating this till the day that you die, right? And so, like, but when you tell a 12-year-old that, it doesn't usually go great, right? You're telling me what? I have to see you once a month for the rest of my life? I have to be taking this medication? So I think highlighting it a little bit differently in, like, you know, this is a medical diagnosis, but we don't really know how long someone may need to be on this medication at your age. What we do know is the substances that you're using are really dangerous and they can impact how your brain is developing. And so if we start this medicine, not only will it keep you safe, but it may prevent you from having a worse addiction later on. Right? And it's a little bit of kicking the can down the road because we don't know how long they're actually going to be on the medication. But I think it also is highlighting to the individual that, like, they're not going to be stuck with this forever, which can be a long time for someone who's 12 or 13. And then integrating addiction medicine into your primary care practices, I think, are key. No one really wants to go to a clinic that's only for addiction, right? So, like, methadone maintenance programs, when you walk through those doors, everyone knows what you're going there for. Right? The only thing that they give out is methadone at a methadone clinic. And so I think making sure that primary care doctors, whether they're family medicine or pediatrics, are prescribing this in their clinics and able to have the behavioral health support, which is sometimes a challenge in our current hiring scenarios. But I think it's really helpful to be like a one-stop shop. And then really, like, pushing back on this replacing one addiction with another. Right? So we know that the hallmark of opioid use disorder is ongoing use of opioids despite consequences. And we know that medications for opioid use disorder reduce and eliminate those negative consequences of their substance use. So you're not really switching one medication or one substance of addiction for another. Those statements are inappropriate. And so I think highlighting that to maybe parents who come in or grandparents and they say, like, well, they're just switching for one addiction for another. And you're like, well, actually, no. Because when they take their buprenorphine, they're no longer having consequences of their buprenorphine use. And so then it becomes a dependence and not an addiction, right? And I think those are key differences. And so talking to people about that. And then again, if you are researchers, please, 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 please do research in this area, because I was looking for about 14 hours this weekend on papers for this specific topic. And as you can see, there are about 3 or 4 that I was able to find specific to adolescents and young adults. And then this is with adults, like, how can we engage people who use drugs in a primary care setting? I think the highlight of this qualitative work is patients want more services, they want flexibility, they want sort of a one-stop shop. They also want attitudes that are not negative towards them when they tell you or they disclose to you that they're using substances. This was a study out of Canada looking at why people don't talk to their PCP about substance use. A lot of it is because they are fear for negative reaction, fear of having their kids taken away, fear of being judged. They had difficulty getting to the clinic. Some clinics have limited hours, and so if you're working until 5 p.m. and the last appointment in your slot is 4:20, then that, like, often doesn't work great for people. So just thinking of some of those flexibility and things that are patient-centered. What do providers say about engaging people who use drugs in a primary care setting? So this is a qualitative study looking at that particular question. And really what providers loved is continuity of care, right? Being able to see that person 5, 6, 7 months or years after you initiate them on medications, and having that relationship is key to engaging people who use drugs. And then also meeting patients where they're at. So, you know, talking to them about their goals, and they may not be the same goals that you have for them, but sort of helping them reach those goals in the hopes that as you engage with them, you can sort of move that goal closer and closer to sobriety, for example, if that's what their long-term goals are. And then learned experience. So again, this is not evidence-based, just based on my own personal clinical experience. I think anytime that you have co-located mental health is key, so that you can do warm handoffs, you can introduce that person to the patient in the room with them. Hep C treatment is also, a lot of my patients who are adults who have Hep C want Hep C treatment. And so if you can do BUP, primary care, and Hep C treatment all in one spot, amazing. Like, people want to go to those clinics, right? Making sure that you're talking to people about harm reduction, and also not forgetting about other healthcare maintenance, right? So thinking about pap smears and colorectal cancer screening. Not so much for adolescents and young adults, because those aren't like colorectal cancer screening anyways isn't, but screening for STIs on top of talking about substance use shows people that you care about their long-term longevity, right? Not just the short term, we want to keep you alive, but also we want to make sure that you're healthy and can live to be 90, 100 years old. Making sure that that patient provider relationship is key. Recognizing that abstinence isn't always the goal and being okay with that, which is hard in the healthcare setting, but it often is the case. And then also recognizing that just because someone is using a substance doesn't necessarily mean that they have a substance use disorder, right? I occasionally drink beer. Doesn't mean I have an alcohol use disorder. And so I think sometimes if someone's like, oh, well, you used a fentanyl tablet, you automatically have an opioid use disorder. Well, we have 11 criteria to determine whether or not we think someone has an opioid use disorder, right? And so we should utilize that and not just jump to conclusions and say, oh, you have a opioid use disorder. I think you can highlight that it's risky to use fentanyl, right? But maybe not jumping straight to OUD without using the criteria. And then specifically around families, which I think are becoming more and more important, and there's more and more research in adults and families. But this was a paper looking at young adults and families and how when you engage families, there's actually some benefit. Again, there's a lot of HIPAA and 42 CFR Part 2 things that need to be dealt with when you're talking to families, especially if the individual is over 18. One of the things, so for the second bullet point, family members should be counseled on evidence-based approaches that can enhance their loved one's engagement and care. So I actually had not heard about community reinforcement and family training, CRAFT, but it's actually been shown to improve engagement 40 to 70% in this age group around substance use. And it's really meant for individuals who may not be interested in treatment, and it sort of teaches families how they can engage with individuals who are using drugs and convince them at some point that treatment might be a good option for them, right? So for example, you don't really want to talk to someone when they're intoxicated, right? Like that conversation is not going to go well. And so CRAFT sort of like outlines to families like what they can do in those situations to be supportive and then having those conversations later. The nice thing about CRAFT is it does not need to involve the patient. So you can refer people to CRAFT without having the patient involved. And then family members should be counseled on resources to improve their own health because it's stressful when a loved one is using drugs or has a substance use disorder, right? And so making sure that they have resources that they need. I think that's my last slide. Questions?
Where can you send families for CRAFT?
Oh, that's a great question. I do not know.
I think we heard upstairs this morning, it sounds like 4D is starting.
Doing some craft?
They're starting a craft for families there, but that's the only one I've heard of so far.
And Jennifer, I'm going to call Clackamas Public Health and say, give us public health dollars so we can, because we have to do it as a prevention thing,
Yeah.
right? Because if the youth isn't enrolled, but we know how to do craft at Clackamas Health Centers, but we end up not doing it because
Takes time.
We need to get to the parents before the kids get to us. So it has to be a prevention model.
Let's get one more, but then I think we'll need to wrap up.
I'm just wondering if you're aware of like any like primary care agencies with like doctors and also like substance use counselors working together under one roof. Does that exist?
Great. Yes, I think a lot of the county health centers have those options. So most of the clinics that I work in, we have a peer recovery mentor. Some of them are CADCs, but not all of them. But yeah, I would reach out to the county health centers would be my first recommendation. After that, I don't know of a ton of places. Virginia Garcia.
My wife used to be the CADC that worked with physicians out there.
Definitely Multnomah and Clackamas both have that.
Multnomah and Clackamas health centers have it. Okay. Perfect. Well, I may see you guys again this afternoon, but thank you for sitting in on this session.